Hi, everyone. This is going to be a really special show. You don't want to miss this. We've had silent killers before, but this is one that's near and dear to my heart. And we'll tell you why in just a moment, but you'd be familiar with it just because of the late now Senator Lindsey Graham. He passed away of an aortic aneurysm. We're going to get into the tamponade versus the dissection versus the rupture. What may kill you, but can you prevent it and stay alive? Find out in just a moment right here on the Heart of Innovation, so don't go away. Christy, take it away.
On our mobile app, tune in, iHeart, and the Odyssey app. We go where you go. AM 1220 KDOW.
Sponsored by The Way to My Heart Incorporated.
Welcome to the Heart of Innovation, 60 minutes that could save life and limb with new breakthrough ideas and innovation changing the healthcare landscape. Brought to you by Patient Advocacy Group, the Global PAD Association at padhealth.org, in partnership with Reflow Medical, the pulse of medical ingenuity. Here are your hosts for the Heart of Innovation, Emmy Award-winning journalist and founder of the Global PAD Association, Kim McNicholas, and interventional cardiologist and founder of Save My Piggies Health and Wellness, Dr. John Phillips.
Radiating back pain, a little bit of a lack of appetite, heart palpitations, maybe shortness of breath, feeling of constipation even a couple nights before. Those were all symptoms that kept my family and I just wondering what is going on with my mom, but we kept brushing it off because 5 doctors brushed off her symptoms. But when she passed away, we discovered it was a silent killer known as an aortic dissection. And here we're going to be talking about it today, right, Dr. John? We have Dr. Sungho Lim from Rush Hospital in Chicago, Illinois. And we're bringing this up today. It's timely. Yes, my mom passed away 4 years ago, still haunts me to this day, still that survivor's guilt. What if, what if, what if? But Senator Lindsey Graham passed away of, I believe, an aortic dissection. Could have been a tamponade, could have been a rupture, but what's the difference, Dr. John?
Well, yeah, so happy Saturday. A lot to unpack here. A timely conversation I think we're going to have about aortic disease. And I think it's great to have a surgeon on because I'm not a surgeon. I'm an interventionalist. We do treat folks with aneurysms, and but yeah, unfortunately, Lindsey Graham passed away from what we believe is an aortic dissection. So often, and we'll get into this, but when the aorta in certain areas can dilate, the arteries are made of 3 layers, and they can tear a little bit or dissect, and sometimes the tear will go kind of away from the heart or towards the heart, and I suspect this one went towards the heart, and then it tore into the sac, that kind of the pericardium, and usually people die from what's called tamponade. So there's fluid or blood that fills that sac. It's not meant to have a lot of fluid, maybe 10, 20, 30 mLs, and when it gets just a little bit more than that, the heart doesn't work right, and folks can arrest and die. So very, very tragic. But I think what we should focus on today is just try to raising awareness, right? So there's certain people with risk factors that need to be screened with an ultrasound, it's never too late to get somebody to stop smoking or talk about tobacco cessation, because that's one of the bigger risks. So it's going to be a good conversation, and really excited to have Dr. Lim on the show.
And before we get right into it, let's start with a moment of inspiration to lighten the mood.
Dr. John Phillips' spectacular vascular moment of inspiration.
Okay, so I don't know how inspirational this is. I think it is. I think it's inspirational in the sense of, someone who wanted to make a difference in a disease that, again, like is very high morbidity and mortality if undiagnosed, and you get a rupture dissection. So Dr. Juan Carlos Parodi, Parodi, he's an Argentine vascular surgeon, and so he pioneered what we call endovascular aneurysm repair. So as opposed to, opening up the belly and a surgeon removing the aorta that's diseased and putting kind of new pieces in, we basically reconstruct the aorta in kind of a pants-like fashion with a waist and two legs. And they were asking him, like, when you thought about these stent grafts, what do you kind of see? What do you think the future is? And it's very timely. So this was in 2002. So just kind of, these are just getting started, but he was in an interview and he said, I imagine a day when an aneurysm patient could walk out of from a procedure after about 15 minutes of work. Now, it takes a little bit longer than 15 minutes, but it is pretty amazing. And Dr. Lim, I'd love to get your thoughts on this. It's pretty amazing what we can do in probably under an hour sometimes with respect to putting these stents in, excluding the aneurysm or rerouting the blood flow. And folks have two little kind of nicks, one in each growing. We watch them overnight and they go home, as opposed to years ago when they were wrapping these things with cellophane and various stuff. So we've come a long way with aneurysm treatment in 2026, that's for sure.
Yeah. Dr. Lim, what do you think?
So, funny thing, like Dr. Juan Carlos, he's also, like, last name is known as Dr. Perotti, and his son was actually attending during my fellowship. So I was trained by
Really?
the one who did the world first, like endovascular aortic aneurysm repair. And I heard some like good stories about him. And he initially, the stent was available, and then he started to sewing fabric around the metal, so that they can put a metal to exclude the aneurysm, but the blood flow will only go into the stent, not going outside, so the sac doesn't get the pressurized blood flow. So that's how they started. And initially they started with just a tube graft, because I assume that it's easier to do so. And then they realized that it kind of keep moving or migrate and has a higher chance of, like, some leaking around it. So they kind of changed it to like a pants-like structure. And now that's a kind of mainstay of the therapy for aortic aneurysm. And I would say about like 80% of the aortic aneurysm repair is now done with the endovascular way, and maybe like a 10 to 20% to be like open surgery in these days.
But you got to catch it early, right, Dr. Lim?
Yes.
I think that's really the catch. And the problem is that it mimics, quite a few other things. What if everyone with high blood pressure ended up getting tested? I mean, is it really that extreme? But the two
Correct.
consistencies, what you have, the back pain, persistent back pain. Well, that could be, what if someone has disc issues or spinal
Correct.
issues or sciatica, and
Mm.
those could be a problem. And patients like my mom were going through orthopedic surgeon after orthopedic surgeon, sent to physical therapy, and then the traction. Even in her final days, they put her in traction. And they never took, is it enough just to take a stethoscope to the belly? I mean, to at least see if there's any pulsating? Is that too much to ask?
So I would say that, I just want to point out like one big difference between the aortic aneurysm and the aortic dissection. So Senator passed away from like we thought that it's from the aortic dissection, and dissection is a tear of the artery wall. And the aorta is the main artery that came from the heart. So it's the biggest artery in the body part. And the artery has three layers: an intima, media, and adventitia. Usually the most inner side of the artery wall tear off from the other two. Once it tear, because the heart is keep pumping, blood's supposed to go into that space, and the tear kind of propagate. Sometimes it goes towards the heart proximally. Then we call it type A aortic dissection. It sometimes can go to the distally. If it doesn't involve the aorta near the heart, then we call it type B dissection. And usually type A dissection is more emergent than the type B dissection.
And coming up next right here on the Heart of Innovation, we're going to find out more of what you need to talk to your doctor about and see if you possibly are at risk or what you should watch out for. That's next right here on the Heart of Innovation on KDOW. Don't go away. Sorry to interrupt you.
Yeah,
We're
yeah.
still
You got to pay the
live on the
bills. You got to
Yeah.
pay the bills.
We're still live online, so just to make sure you know, say hi to everyone on our YouTube channel. While you're there, like the video, subscribe to our channel. It really helps us to get the word out because this is a really powerful message that we're putting across today. Although we always put out powerful messages, but this could literally save someone's life. And so it's, I want to get into, I mean, is it ever a problem just to ask the doctor to check? I mean, if you do have persistent back pain, if you do have extra high blood pressure, um, can't you at least ask? And is a stethoscope just to the belly, is there an indication there? Would love to get into that.
Yeah, we can. I think we can maybe come back talking about some of the risk factors for developing the aneurysm, and then I always, you're talking about screening there as well. It's kind of funny because we had a few years ago we put up some posters in our office to say, if you've ever smoked and you're a guy over 65, talk to us. We can screen you for an ultrasound, and a couple of my other docs, the docs were like, yeah, we don't want those up there. The patients
30
ask too many
seconds.
questions, and it's just so, because when you put posters in the rooms and they're sitting in there, they read those things. And one of our physicians was mad that he was getting asked about, because he's not a vascular, he was general cardiologist. He was mad that he was getting asked about aneurysms.
And the Rush actually had like a kind of promotional, like a screening for like a
Yeah.
coronary disease, PAD,
Yeah.
carotid.
And Josh has some questions over there in the chat at some point we should get to.
1220 KDOW.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back, everybody. Happy Saturday. Thanks for joining us. So let's continue the conversation. And Dr. Lim, let's focus on the aneurysms, okay, and what we call AAAs, so abdominal aortic aneurysms. So we look at risk factors, right? And the big ones: smoking, male sex, family history. When you see a patient in the office, for example, are we doing a good enough job at identifying people at risk, and then making sure that they're getting screened if appropriate? Where are we kind of missing the boat here with this disease? Because to Kim's point, it's the silent killer. You don't know you have it oftentimes until it's too late, and then often the mortality is so high if it ruptures.
Correct. So, those like screenings are oftentimes done by primary care physician. And, I think that it's like something that we have to push forward to the primary care physician or family medicine, like a training that like a AAA can be like one thing that can kill your patient. So as of now, I think that the U.S. Preventative Service, like a task force, like recommended one-time screening if you are a male somewhere in the age between 65 and 75 with any history of previous smoking, and they recommend one-time. And so that being said, someone who is even older or female, or someone in the age between 65 and 75 but never smoked, and it's actually there's no recommendation to repair or screening. And in fact, for female with that age group without any smoking history or any family history, they recommend against the screening, which is interesting, I would say. Yeah.
Wow, it's interesting, even me. So because my mom ended up getting screened, my younger brother got screened. My brother has multiple dilations. And so I ended up getting screened, and I have a very slight dilation. And if you didn't know my family history, I did have one cardiologist brush it off and said there was nothing. But the cardiologist that knew my mom said, we're going to keep you coming back every few years, and we're just going to watch your blood pressure. I've never smoked, but now I'm under investigation for a possible, I guess it's a tissue disorder, because if it runs in families, there might be a tissue disorder. And so, it's nice when people, and especially primary care, is on top of it. And it doesn't seem to be for everyone. why not take the stethoscope to the belly? I mean, I don't understand. I know they used to. And when you're younger, remember they used to, check your neck, check your heart, put it on your belly, whether it's gut issues or whatever they were listening for. And then they would touch your feet, and they just don't seem to do that anymore. A little birdie told me it's because there's no reimbursement for the belly. I don't know if that's true.
Well, I mean, like you don't have to
I opened
have
up a can of worms.
I mean, you don't have to have a physical exam to bill, okay? And so, for me, we talk to primary care doctors about like just assessing for PAD, for example. Like if someone even feels the person's pulses, like to me, that's a win. To ask them to evaluate the abdomen, that's a tall order sometimes. And so we often, we do it. But again, I think to the previous points that were made, like we just have to be aware of people who are at elevated risk, and get them screened, I think, at least.
So I just want to make sure, am I on point? What can you hear? What do you hear? What do you learn from just even a stethoscope placed in the right area of the abdomen?
Dr. Lim, I don't know about you, but I'll put the stethoscope. I'll try to feel someone's aorta, so we try to palpate it and feel if they're, but unfortunately, a lot of folks have some distance between their skin and the aorta, so it's a little bit difficult. But in same thing too, if you try to listen for a bruit or abnormal noise or something like that. But I think we're a biased audience, right? Because we kind of play in the sandbox of these disease processes. But I'm very, very liberal in screening patients. I don't have too many. I think it's often an anomaly, at least from what I see, when the patient has had a AAA screen from their primary care doctor. It's just maybe it's something they're just not thinking about.
So
do you find? Oh, go ahead.
So yeah, from my standpoint, like aneurysm is not something you can hear with a stethoscope. If there's like a narrowing, it actually makes a little bit of sound. So the blood flow has to go through like a narrowed blood vessel. That's what Dr. Phillips just called as a bruit. So some people, abdominal bruit sometimes means that there's like a renal arteries like narrowed, or the mesenteric arteries narrowed. That can be something. But AAA is not something you can hear, but you sometimes can feel it if it's large enough. But as Dr. Phillips mentioned, it's the aorta is the biggest artery in the belly, and it's usually hiding behind a lot of stuff. So it's like actually the deepest portion of the body is right on top of the spine. So unless it's like huge, it's very difficult to feel it. So that's why, it's like the silent killer is like a perfect makes sense, because it's asymptomatic until it becomes a problem. And most of my patients, in my experience in my clinic at least, because nowadays getting an ultrasound, getting a CT scan for any other region is so common. Someone who came into the emergency room has some abdominal pain, they just get a CT scan to check. Those CT scan will like incidentally found some small aneurysm, and that's how they ended up to come to my clinic. That's the most common scenario, asymptomatic patient.
Yeah.
And then there are risk factors I just want to go through just really quick, because we've talked around it, but it is being overweight or obese, not exercising regularly, eating a high fat diet, and smoking, even high blood pressure can lead to an aortic aneurysm.
Right. So if you kind of look at it, male sex, smoking, those are the two big ones, and then less likely coronary artery disease, hypertension, all that other stuff. So I was Googling some prevalence. And so it's interesting because the prevalence of AAAs has gone down over the past 2 decades, presumably because we're doing better at telling people to stop smoking and reducing smoking. And I think we're also getting better at reducing cardiovascular risk. But to Dr. Lim, his point, so let me just throw this out there. What do you think so let's say if you rupture, Kim, if your aneurysm ruptures, what do you think the mortality rate is? So what are the chances of that person dying if it ruptures? 50, 80, 30? What number do you think?
I know just from my experience, it was 100%, but I think that 80%,
Yeah.
it would be the number I'd guess.
Yeah. And even if you get them to get to the hospital and you get a surgeon in there and whatever, I mean, they still have almost what is in a 50% mortality. So it's just we've got to get better at screening folks. And we also have to keep beating the drum about tobacco cessation.
Now, in terms of the folks that come to you, Dr. Lim, what is the percentage of those that ultimately end up needing a procedure versus those that maybe you can delay or prevent a procedure with lifestyle modifications in medicine?
So
In
my
1 minute, in 1 minute.
so my practice may be a little bit biased because I'm in the tertiary like a referral center. So depending on the size of the aneurysm, that's what it matters the most. So for male, if it's greater than 5.5 centimeter, I recommend to repair. Female, if it's greater than 5 centimeters, I recommend to repair. That being the reason why the female that we repair a little bit smaller size is this female has a little bit smaller artery to begin with, and the artery gets bigger, it has a risk of rupture and it gets higher. So that's why we do that. Anything aneurysm 4 centimeters or bigger, we recommend yearly follow-up. Anything smaller than 4 centimeter, I recommend every 3-year follow-up. And me being a specialist, I just cannot check every 3 year on this patient, and I usually have to defer this follow-up to their primary care physician or even to the patient himself.
And coming up right here on the Heart of Innovation, we'll have more with Dr. Sungho Lim from Rush University Hospital in Chicago, Illinois, talking about aortic aneurysm. So stay with us right here on the Heart of Innovation on KDOW. Don't go away. Perfect.
What percentage of your ruptures are you guys doing endo? I know our surgeons are doing like almost 100%.
We always try.
Yeah.
Always try. Yeah. But my training, I usually tell them, don't push too hard. If you don't think that an E-bar is not gonna work, don't even try. Because when you do an E-bar and then convert it to open, they die.
Yeah.
They all die. Yeah.
And it's hard too.
Right.
I always, my thing is we've had several patients with them and they always ask me like, Kim, what should we get the open? They only want to do open. I said, you know what? I don't, with aortic aneurysms, I don't mess around, whatever the doctor whatever they're going to come up with. Like, you just go with it, what they're comfortable with, you just do, because this is literally your life on the line.
I mean, I think Sungho, correct me if I'm wrong, but probably 89 or greater than 85% of aneurysms are done endo, at least the end of AAAs are. Mm-hmm. And now with fenestrations and all that and physician modified, it's, I mean, you guys do a lot of open still or no?
Less and less. Yeah, that's a challenge for us, like for our trainees. Because when I was a trainee, we were all already told that, like, you guys are much less open than the years before. And now it's even less with those like fenestrated E-bar and physician modified graft. So all those like are now taking place, like all open. But like the good thing to be here, like, there are some indication that we have to do open, like an infected stent, that we have to get rid of it. Some like a fissurized, so to like eroding into some bowel, then we have to get rid of it. Yeah.
Do you keep people overnight for EVARs?
EVARs, yes, we keep 1 day.
1 day, yeah.
There are some hospitals who do a same day. I don't know whether that's like something I would do for like, it's still aortic surgery.
Yeah. It's interesting.
Yeah. Your institution like do a same day EVAR?
No, like it's interesting because we're one of a few groups of that, as I'm an interventional cardiologist. So we're one of the few groups that we do EVARs on our own. Now, typically we'll work with our surgeon or we always work together because we want to keep that relationship. But we're kind of a dying breed, I think. There's not too many of us out there left. And I really enjoyed, and I like doing the EVARs. I don't really like doing endo leaks and things of that nature. But
EVAR is a good procedure. It's a macro, unlike your coronary, that like 014 wire, that's like
30 seconds
to see.
Yep. So is it okay if we go back into the next segment and maybe just for the listeners, get in their minds, tell them like, what the normal size of an aorta is and like, the whole aneurysm, because that's very confusing for patients and
Yeah.
PCPs to some degree as well.
And, it depends on the size of the body. Like they said that my mom's, and I don't know what's true or if they can tell that, but the coroner's office
1220
wrote it
KDOW.
4.7 centimeters. Like, is that even
Welcome
possible?
back to the Heart of Innovation.
That's
For
small.
more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Thanks for joining us today, having a wonderful conversation about aneurysmal disease. So, Dr. Lim, explain it to me like I'm in kindergarten. What is an aneurysm, and what am I the size of my normal arteries, and what if it's big? When should I be worried? Because a lot of folks they are reading their charts now, and they're inspecting, dissecting every word, and it says this, it says that, and they don't speak the language we speak. So how do we not dumb it down, but how do we create a dialogue or a language that people can understand?
So I usually explain that aneurysm is like a dilation of the artery. And the definition is like if it is bigger than 1.5 times than it should be, that's what we call like aneurysm. And as you can imagine, when the artery gets bigger, wall get thinner, like the same thing as a balloon. And when the balloon cannot tolerate the size and the pressure gets higher, it just pop and open and it makes like internal bleeding. Yeah, so different level of the artery has a different normal size. So in general, in the abdominal portion, if it is greater than 3 centimeters, and we start to call it as an aortic aneurysm. And the artery a little bit, in the arm usually is smaller. So we usually don't call it like, if it's 3 centimeters, it's pretty big for arm artery. So then we should call it as aortic aneurysm. But the definition is 1.5 times bigger than it should be.
Okay.
It was interesting. My thoracic was 3.7, and they called it a very slight dilation, which my one cardiologist, actually noted it. The other one said, "Oh, you have nothing going on." My mom's, and I don't know if this is possible for the coroner to have seen this because it dissected. They called it a slow dissection. Would love for you to go through that as well. And maybe why she experienced more alleged symptoms than maybe other people do. But hers, they claim, was 4.7. So that's under the level that you stated that you would actually treat a woman.
Correct. So the thoracic aneurysm. So when aorta comes out of the heart, it starts to giving branches. The first branch will go to the right arm and the right brain. The second branch goes to the left brain and the left arm. It turn around and go to the belly. So the thoracic aorta, before it gives all the branches, it's actually bigger than the abdominal aorta. So thoracic aorta, we actually wait until it becomes 6 centimeters.
Oh, wow.
Yeah.
Because it should be bigger to begin with. In an abdominal aorta, it's already given all the branches, so the blood vessel gets a little bit smaller. So abdominal aorta, we repair if it's greater than 5.5 for male and 5 centimeters for female.
So let me get your thoughts on this, because a lot of patients, we start when it's above 5. I always tell the patient, I'm like, listen, if you're above 5, you're going to get to 5.5. And so some people oh, this is the sword of Damocles hanging over me. I want this repaired. So we often do it, and sometimes we'll repair it earlier because, if their arteries are a little crusty, it's kind of like, your arteries are going to get more crusty. But so are you guys pretty rigid with that, the 5.5 versus 5, or obviously you make exceptions, right?
Correct. So we have exceptions. There are a few of those. The most common thing that we repair a little bit early, we usually call it like a rapid growing aneurysm. So 1 centimeter per 1 year or half centimeter, half a year growth or bigger, then we usually call it as a rapid growing aneurysm. We know that that's going to get to 5.5 centimeters in near future. So we repair it up front. Someone who has we call symptomatic aneurysm. So someone who has an aneurysm and they have a pain, and when I press it there, like they have a more pain. And, those one probably aortic aneurysm has some inflammation or even sometimes have an infection. Those ones that we probably offer them a surgery sooner than later, because those wall can get weaker and then have a higher risk of the rupture. Another one, all of those aneurysm studies that we know of, 5.5 centimeter aneurysm has a risk of rupture, like a certain, percentage. Usually we usually say 3 to 4%. But those studies were done in the aneurysm that we call like fusiform aneurysm. So as a smooth taper of the artery, I actually have a model, something like this. So I have some smooth taper of the dilation and then smooth taper back to the normal size. Those are like fusiform aneurysm. Those are the ones that how this is gonna behave like a year or two later. But compared to this one, there's an aneurysm that we call saccular aneurysm, which is a straight down, it almost like a blueberry coming out like that. Those aneurysm, we don't know how that's gonna behave, so we usually tend to repair up front when we see those.
Mm-hmm.
And so it seems to be that if you saw my mom, if she was symptomatic and she was only at 4.7, that would be an indication to actually treat. And can you go into a little bit more of the slow dissection, that moment that maybe she felt some sort of tear? She described it as a tear, and the emergency room doctor said, "You just pulled a muscle." But later, the cardiologist said that was a sign.
Can I ask him? So was your mom? Was it the thoracic aorta
It
that
was
was
abdominal.
that tore?
Abdominal.
Mm.
Not
And so they
interesting.
think that she died from the dissection.
That's what they said. It was actually in the autopsy report.
Oh,
Interesting.
so the funny thing is that dissection can happen like out of blue. So like like every heartbeat, the blood vessel get those flow coming out with a high pressure. So the inner lining of the artery always has a shear stress. So it has a risk of dissection. And having an aneurysm, yes, it's a risk factor for making a dissection on top of the aneurysm, but it's not always happens. And the funny thing is that when aneurysm gets like that big, like 5 or 6 centimeters, it usually doesn't make up. It's more common to have a dissect the size of the aortic aneurysm that prone to have a dissection. It's usually not like 4 to 5. It's actually even smaller. So
Yeah.
it's like something that we still don't know how this aneurysm is going to behave. Is this going to get into the dissection in near future, or is it just going to stay as an aneurysm? We have to wait until 5 centimeters. We don't know. And like
coming up next, right here on the Heart of Innovation, it's why you just need to have the conversation with your doctor to determine the right course for you, and if regular monitoring is right. So stay with us right here on the Heart of Innovation. We'll help you with that conversation. Coming up next on KDOW. Don't go away.
Keep an eye on this chat.
Yeah.
Yes. I'm curious, and even just if we want to wait, to go on the air on this, but I don't know if you know. So I was a regular journalist on television, did these local news stories. I did national news stories, and when I watch the news stories on these diseases, whether it's PAD or aortic aneurysms, I'm always like, oh my God, you missed the main part. I'm curious, in your area with so many university hospitals, how did the journalists do there with the stories? How'd they do with yours? Did you feel like, oh my God, you should have asked me this, or I wish you would have put this part of the conversation in there because it's a disservice to patients? Like, what the heck?
I mean, like you have been doing a great job, and I actually read that those questions that you're gonna ask me, so I actually have to study a little bit last night about it.
Good for you. Well done.
Those like actually screening, I actually never pay attention because all the patients already screened before they come to my clinic. I just didn't pay much attention to that part of it. And but I don't know whether this is like worth mentioning in like a live show, but like the screening, to make the screening meaningful, we have to prove that the screening makes the aneurysm related mortality lower. And those people who like a male 65 history of smoking, those are the ones that actually have a lower aneurysm related mortality after the screening. But the all-cause mortality is actually unchanged.
Yeah.
So is it still like a grade B, like a recommendation? Yeah. So, it's like those are like kind of too deep dive, like for the publics. But like those are the
And
ones that
sometimes too, you get, the kids, because it's oftentimes dad's in the office visit with, the son's there too, or the child's there, and then they want to get screened too, and they're not technically of age or whatever, and I'll make something up like, oh, you had belly pain, okay, we'll get you screened. But I always tell patients,
It's a good
I'm
doctor.
like, if you have any, if you what's that? No, no,
I
well,
said
I
that's a
mean,
good
I always tell
doctor.
patients like, well, thank you. You need to talk to if you have any like any siblings that are still alive, they need to get screened and, make sure that you're telling people about your aneurysm that are your first degree relatives. Because obviously the genetics of it. Now, how often do you screen for like popliteal aneurysms and things of that
Oh,
nature?
yeah, good question.
anyone who has a AAA, I screen for their popliteal aneurysm.
Yeah. Yeah.
And
Can you
anyone who
guys talk about that on air, please?
yeah.
Too?
Yeah. Can
Sure.
you also mention about the symptoms? I want to actually talk about the symptoms.
Yeah.
So
Okay.
Yes.
yeah.
Good call. Good call.
Segment 4 is 7 minutes. Okay. Short.
Yeah.
I know we have to have you back, Dr.
Okay.
Lim.
Yeah.
If you'll so
How's
have
your call?
us.
Yeah.
You guys get called in a lot?
For us?
Yeah.
Yeah, recently, yeah, it got busier.
But I mean, you're just coming in for a procedure, right? You've got fellows and residents and
Correct. Yeah.
so. Although it is the new year, so you got to
30
hold their
seconds.
hands.
Yeah, like July is the toughest in general.
That's the worst time to go to the hospital.
We've already had a couple experiences of one in Florida and one in thought it was Georgia.
Hmm.
Yeah.
Got to crack a few eggs to make an omelet, unfortunately.
Gotta learn somewhere and somehow.
This is SRN News.
Folks for a better doctor later, they learn early.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Dr. Lim, let's switch gears a little bit. Let's talk about symptoms, okay? Because we were discussing this during the break. What should people be thinking about, or I guess aware of, with respect to, let's start with just a AAA, the aortic aneurysm?
So, the funny thing is like, aorta in the blood vessel is everywhere in your body. It's in your brain, it's in your neck, it's in your chest, in your belly, and the legs too. So, any aneurysm or dissection can make any symptoms. So like having a chest pain, like it's kind of ripping off symptoms. Can it be a aortic dissection? Yes, it can be, but like, can it be something else? Yeah, it can be from the heart, it can be from the lung, it can be from the muscle and the bones too. So it's very difficult for, as a clinician, to, like, oh, ripping pain, do I have to get a CT scan, or do I have to get a, echocardiogram to check this one? It's like a kind of fine line. Some people may say, oh, like the doctor wants to make all the money and they just want me to get through all this testing, and it's like $1,000 to have to pay out of pocket. Versus some, like, what if we miss it? We didn't get a CT scan because we thought that this was something from the muscle pulling, and then they got a CT scan, it was negative. Oftentimes it's negative because the chance is not high. So it's a kind of difficult problem for us, or even for the physicians in the emergency room. So I don't know whether you have any thought on, those, from Dr. Phillips, or even Kim as a, non-physician, have some, some personal experience about the aneurysm and dissection in your family.
I'll just say real quick that, yeah, I mean, there are a lot of vague symptoms. The vast majority of people that I see, kind of like you, it's biased. They're coming to me because they have an aneurysm. And now you have to kind of talk them off the ledge a little bit. Like,
Right.
it's going to be okay. We'll keep an eye on it. But I imagine it is very difficult in the emergency room, and which is why you alluded to this earlier. I mean, you come into the emergency room with a hangnail and you're getting a CT scan of your chest, abdomen, and pelvis, basically. And so, I mean, like it's a shotgun approach, and on rare occasions they find it. But it's tough. It really is. But I think at the end of the day, we just need to be more aggressive about screening, and it's assessing people who are at risk and trying to help them and trying to lower their mortality.
I think it would be so important because we've already had 4 patients that, because of my mom's situation in our organization at the Global PAD Association, that I've actually said to them, hey, you know what, it might be worth checking. And one of them had a 5.3, and she's a tiny little thing out of North Carolina. And thankful for, have to give him a shout out, Bobby Mendez out of UNC for his work. And Dr. George Adams is the one who called, and I called him and I said, I think I got a problem here with this patient. And he said, I'm getting a hold of Bobby Mendez. This was on Mother's Day a year ago. And they got her in, and they got her just in time. And it almost brings tears to my eyes because of it. Had another friend, though, who, and hers was just kind of a weird abdominal cramp, lower back pain, radiating type of situation. Another one was one of my good friend's moms who ended up, they brought her in, they said she had a potassium deficiency, and then, brought her in, admitted her, and then released her the next day. They were driving away from the hospital, and the mom was like, you know what? I just have this weird pain in my lower back. Something's not right. And the daughter calls me, is this what your mom had? And I said, yeah, drive her straight to St. Helena Hospital, where Dr. Laird, if you know Dr. Laird, was there, and they were able to help her. The one thing with her, and I'm curious from your perspective, is what is the policy or protocol post-procedure for, especially for open situations? Do you prescribe blood clotting medication? Because I've known now with her and one other gentleman that turns out knew the family, that they died of a blood clot post-open because they weren't given any anticoagulation medication. I don't know if that's normal or those were 2 anomalies.
So I usually don't prescribe blood thinner unless there is any other indication for those. And also like the same thing for like an endovascular. If it is a regular endovascular aortic aneurysm repair, I don't prescribe their anticoagulation, but I do prescribe them for at least a baby dose aspirin and statin, because now we kind of replace some portion of the artery to an artificial blood vessel, and I think that it's helpful to just treat them as if they have some kind of like a coronary artery or cardiovascular disease. And aspirin, baby dose aspirin, has known medication to lower the cardiovascular morbidity and mortality after the surgery.
Yeah, you touch on a good point there too. Is these folks have a higher percentage of coronary artery disease. So we're often stress testing, or, I have a very low threshold for stress test. When I first started back in 2011, my partners were doing diagnostic angios for sizing of the aneurysm and then shooting their coronary arteries as well. I don't know that you need to do that, but I think making sure that if you're not doing something objective to assess for coronary artery disease, at least being aggressive with reducing their cholesterol, their LDL to, I go for less than 55, and then doing a baby aspirin. I agree.
Also, someone who got the aortic aneurysm, I also screen them for the popliteal artery aneurysm.
Yes. So where's the popliteal artery in under a minute? Where's the popliteal artery, and why does that one become aneurysmal and others don't?
So popliteal artery is like an artery at the level of the knee. Somehow, like artery, like in the patient with some aortic aneurysm, I think that they have something in their gene or some kind of like other cause of it. So someone who has an abdominal aortic aneurysm, about 5% of the patient will also have a popliteal artery aneurysm. And in the other side, if you are diagnosed with a popliteal artery aneurysm, about 20% of people will have abdominal artery aneurysm. So when I see one of those disease, I check the other side to make sure that I'm not missing anything. And when my patient have both problems, obviously whatever it meets the criteria for repair, I repair first. If both need a repair, and I address abdominal aortic aneurysm first, because if it ruptures, it can be a life-threatening issue. Usually, the popliteal artery problem, if it happens, the worst thing can happen is they can lose their leg, but not the life.
Well, we know that that's really important. Coming up next right here on the Heart of Innovation on KDOW, a few more thoughts on the popliteal aneurysm and what you need to know. Also, some final thoughts from Dr. Sungho Lim on how you can protect yourself from an aortic dissection. So stay with us right here on the Heart of Innovation on KDOW. Don't go away. Just so you think so it was probably with my mom's. I'm wondering if it could have been a little bit higher. Then they didn't really specify. They called it an AAA, but I'm wondering just if it was a little bit higher.
I don't know
as
that
well.
I've ever
Maybe it was a long.
seen. Yeah, I mean, I don't know that I've ever seen anybody die from a dissection in the infrarenal aorta. I mean,
So
you
was
can
it?
have, the limbs can, I mean, you can, I guess in theory, if you just completely shut off blood flow, you could have lactic, all that stuff. But yeah, that's why I was curious.
Because they think that it would happen when I talked to the cardiologist afterwards. I don't know because that's not my thing. But they claim that when she supposedly felt this tear, possibly, but it was weird because it was up in more of the rib cage. She felt this tear, but she couldn't put her finger on it, whether the pain was coming from the front or the back.
So that's the most difficult part for us. Like, is this abdominal pain is from the aneurysm? Is this a symptomatic aneurysm, which we think that it's an urgent issue to deal with, versus the aneurysm has been there and it has been stable, and now you have a different problem from sciatic nerve issues or the spine issues or the musculoskeletal issues. It's eventually your, like, a clinician's decision whether we kind of do something about this aneurysm right now versus it's okay and send patient home and just check it like a month later. Yeah. And me personally, if I have any concern, I rather repair it than let them go home, because when they go home, if something happens, they may not come back. They may, die at home.
Yeah.
So is it possible it was like slow, but it then ruptured?
So slow dissection, it doesn't make sense from.
No, I don't know. I'm never. I was trying to figure it out. I was like, who says a slow dissection?
Yeah, I tried to ignore it, but like.
I know. I just don't know. I'm only going by what they said. Like, none of it makes sense to me.
What did they say was her cause of death?
That's what aortic aneurysm. So I thought it said aortic I thought it said aortic dissection. It could have said aortic rupture. I can go look again, but. Yeah. Is there a difference? She died in my arms, like she couldn't talk. She just was like, and I said, we thought maybe we put oxygen on her because we had a little oxygen can because we were up in Tahoe, but I held her. She just passed away right in my arms. She didn't want us to call 911, but she knew 2 weeks beforehand. She's like, I don't think I have long to live. And we're like, what's wrong? You have a bad back. Like, what the heck? What are you talking about?
KDOW.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Okay, kids, we have 3 minutes and 33 seconds exactly left in this show. So, Dr. Lim, some final thoughts. What, if you could say two things to the folks that are listening with respect to raising awareness for aneurysmal disease, what would those two things be? So,
if you have ever get a CT scan in the past in your abdomen, they should know whether there's an aneurysm or not. If you have an aortic aneurysm, if you have a weird back pain, chest pain, muscle pulling, ripping pain, when you go to the emergency room, let them know that you were diagnosed with an aortic aneurysm. That really helps and just like a ding the bell, oh, hey, this guy can have like an aortic dissection, aortic aneurysm rupture. They will get almost automatically get a CT scan.
It was interesting. We have this gentleman who's in our network, and he was a marathon runner, and he ended up with an aortic aneurysm. And he said that he went into the bathtub and he felt this pulsating, in his belly, and he knew something was going on. His primary care at first brushed it off, but then he's like, you know what? I think I need an ultrasound. And ultimately it was a 5.5 centimeter aneurysm, and they rushed him right in. So it's just interesting. I mean, how, do you just know as an individual? I know for my mom, she had an impending sense of doom. And I don't know
Yeah.
if you've heard that before from your patients.
Yeah, it's actually in our textbook. The feeling of
Really?
doom. Yeah, it's like either impending rupture or rupture patient. They feel something's going on in their body. Yeah.
They just don't know what.
Correct. And they just need to come to the emergency room because when the aorta rupture, here's my the way of like explain to my patient. If it ruptures at home, 50% of patients cannot even come to the emergency room. Among those who made it to the hospital, another half will die either during the surgery or immediately after the surgery. So Kim, you're right, about 80% of patients will die if it ruptures before we repair.
Yeah.
So obviously just more needs to be done. I know it's a big deal over in England as well. They have a full-fledged screening program for men in particular. And I just think that we need something more here in the US as well. And I'm sure you agree.
Well, we wrestle with that because it's the margins and the return on that investment is not, it's the same thing with screening ECGs for athletes, looking at hypertrophic cardiomyopathy or whatever. Like we don't have the person power to do it. But bottom line, over the age of 65 and you're male and you smoked a cigarette, get screened for an aneurysm.
Yeah. Chat with your doctor. CHAT, carotids, heart, abdomen, that you can feel the belly, right? Get
What's
rid
the
of the
T?
few more layers.
Toes?
And then T for toes, for peripheral artery disease. And
Piggies, yes.
for more great, save those piggies. For more great topics like this, go to youtube.com/the way to my heart. Thank you, Dr. Lim.
Thank you.
Thank you.
Okay, so a couple two quick questions for each one of you. And we'll say goodbye to our folks on YouTube. Thanks for joining us. Before you leave, make sure you do like the video, subscribe to our channel, please. And if you have any more questions about this, just put them right there in comments and we'll get them answered. I'm sure Dr. Lim wouldn't mind if we sent a few questions his way if you have some post questions.
Okay.